I am Dr. Karen Evans, and I'm a plastic surgeon at MedStar Georgetown University Hospital. I see patients that have chronic wounds, either from surgery or from trauma or an accident, and their body is not healing for one reason or the other. So diabetic patients that have foot ulcers or leg ulcers, we have a team approach to manage those patients to prevent amputation. In addition, if you've had surgery for one reason or another and that incision is not healing very well, then I will see patients like that and help them heal and move on. We consider the skin an organ. People don't think of a skin as having a damaged, system. It's really almost a window into what's going on metabolically inside you. Usually there is some factor, whether it be an underlying infection that has not been really clinically looked at, whether there is diabetes or nutrition issues, autoimmune issues. Those are all the things that we really have to make sure that we are managing and looking at, because whatever we do won't work unless you've managed those intrinsic factors. I think this wound center is very special because, number one, we have a huge team of people. We have internal medicine, infectious disease doctors, vascular surgeons, podorthotists that help with the shoes, prosthetists that help with the prosthetic that patients need after an amputation. We have rheumatologists that really help with managing complex, very complex medical problems. In addition, we have hyperbaric oxygen, which is an adjunct to wound healing. And we also have research. So by combining so many different aspects, it's a very special place. And obviously being led by Dr. Attinger, who's an internationally world-renowned plastic surgeon in the field of wound healing, has dedicated his life to this. We really look at function as the most important endpoint, getting patients back to work or back to their life or able to walk. Most patients come back and they're just so thrilled that finally this wound has healed that has been there and affected their life for so long. It's extremely satisfying to finally get a wound to heal and to see new tissue or to see the skin that's finally there after so long. Patients are so thrilled that their wounds have healed, so it makes us very happy. It's an honor, really. So the skin is an organ in our body that we forget about a lot. It serves to protect our body, all of our internal organs. So it's an external organ that is very complex, actually has multiple cellular levels, and the purpose of it is to protect structures. We live in an environment of organisms, and so the purpose of it is, again, to protect us. So some wounds do not heal because your body hasn't recognized it as a problem. So it's what we call a chronic wound, that the cells that are around that wound have sort of gone to sleep. They are not receiving the signals from your body to heal. And that could be from diabetes, that could be from end-stage renal disease, malnourishment, or an autoimmune problem. And there's rare diseases to more common diseases like lupus that make it so that your body is not able to send the right signals to allow for final healing. So that's where what we call an acute wound has turned into a chronic wound, and your body isn't able to heal it. If you have a wound that doesn't heal, you should see a surgeon or your primary care doctor or a physician if it's not healing in about 3 to 4 weeks. You really should be able to see a natural progression over time. So it's slowly improving. You can tell that the drainage has gone down, or that the thickness of it is getting thinner. In terms of it was a deep wound and now it's filling in, things like that. You should really see natural progression. However, if you aren't seeing that, it's important to seek a medical provider. When the wound is deep, so that if there's exposed bone or tendon or other structures that are deeper, that's when we tend to be a little bit more aggressive and concerned, because what we don't want to have happen is an infection. We live with staph and strep, which are organisms all over our skin. So when you have a break in the skin, what can happen is an infection. So the whole point of wound healing really is to prevent an infection. And if you see signs of infection like redness or pain or swelling, that's called cellulitis. If there's drainage that is, foul smelling or pus, those are considerations that I would say you need to see someone much sooner. And again, if it's exposed bone or tendon or a deep wound with signs of infection, that's where you really need to be seen very soon. If you have a wound and it's closed with stitches, what happens is over the next 48 hours, it's a pretty amazing process that your body sends new skin cells across that little stitch line. So in 2 days, incisions are what we call epithelialized, or cells have gone across and healed within 2 days in a normal process. If you haven't stitched it closed, so it's an open sort of chronic wound, it depends on how deep it is, and it also depends on how large it is. So it depends for every person how long things will heal. If you have a wound, there's multiple things that you can do to heal faster. Number one, I think, obviously being in partnership with someone who's focused on your wound, that can change different dressings that we can use to help optimize your ability to heal, and to have someone measure the wound every week or 2 weeks to see how things are doing. And that's number one. Number two would be to, if you're diabetic, to keep your blood sugars at a normal level. That's one of the most important things that diabetics can do, is to check their blood sugars and make sure they're on a good regimen and their blood sugars are in control. And then number three, there's nutrition factors. So if you are malnourished for whatever reason, we look at albumin levels or protein levels, and those are very important signs, or very important factors that we try to optimize by giving protein supplements or other supplements to help healing. If you have been radiated for whatever reason, whether it be cancer, breast cancer, or other cancers, radiation can also affect wound healing. And so there's a lot of data that suggests that hyperbaric oxygen can aid in wound healing in the radiated patient. So there's multiple different things that we can do and help educate patients that they can do, so that we can get wounds to heal without needing a complex surgery, although sometimes that is needed. Diabetes affects your entire body because the blood sugars rise inside your body, and proteins that are part of our cellular structure and keep us, alive, and proteins become what's called glycosylated, meaning sugar actually bonds or gels to parts of your protein in your body. So normal cellular mechanisms, in other words, normal pathways that allow you to heal, are impeded, number one. Number two, there's a component of what's called neuropathy, so that patients don't feel their feet or other parts of their body. They have no feeling whatsoever. And so when you have neuropathy and you don't have any feeling, you can have a wound that you don't even know is there, and that can become much deeper or a problem. Charcot is another component of the foot, of the diabetic foot, and Charcot means that the ligaments in the ankle or the foot are destroyed from the diabetes, and because of that, your bones actually collapse and they cause pressure on abnormal places of your foot. So diabetes affects really all the pathways in wound healing, from the nerve issues to the bony structures to the cells. So that's why it's very important to keep your blood sugars at a good normal level. Recovery after surgery is really an important part of the whole picture. So we have a very dedicated focus on the discharge in our hospital. So if you have surgery here, we spend a great deal of time on going through education with you about things that you can do and you can't do. And that's simple things like, can I shower, with this, new incision? Can I walk? Can I drive? All these simple things. So we have two nurse practitioners that help us on a daily basis and go through all the patient, instruction handouts. And in addition, we usually see our patients within a week after leaving the hospital so that we can go through those again, because it is sometimes a lot of different questions and things change over time. Showering in general is okay. There are certain times we don't let patients shower, but soap and water on a closed incision is fine. And there's data that show that even simple, again, people always say, what kind of soap? Are you sure I can use tap water? There's data that show that soap and water is fine. There's certainly patients that would rather use saline or a sterile solution, which is also fine. But the important thing is to keep things clean as possible, keeping your eyes on the incision, seeing if there's any changes, and just keeping it dry so that it doesn't get wet and moist. So I think the advantages of being at an academic medical center are multiple. Number one is the constant focus on delivering the best possible care, and that involves multiple factors. Research is a big component of any academic medical center, so there's always a thought that there's a better option out there. Let's try to find it. When you're at an academic medical center, there's multiple different departments that are collaborating together. So that means that you have internal medicine, you have general surgery or neurosurgery or orthopedic surgery, and all these departments are very much on the same page and collaborating. Will you need an amputation is a very complex question. And the first and foremost consideration is how can we get this patient who is maybe looking at an amputation as functional as possible. So that means that there are multitude of surgeries that we can do to save a leg. However, if that leg is not functional, if it can't bend, if the ankle can't move, if you can't feel anything in your foot, if it's a non-usable, as we say, a non-usable extremity, then it's better actually, on some cases, to get an amputation, because the prosthetics that are available now are pretty amazing. There is a fine line and a balance that we weigh in terms of all the surgery that we love to do and love to offer. Is that better or worse than, quote, a man-made leg or a prosthetic that can offer sometimes more function than what we can offer? So sometimes it's the bony structure, if the bones are just not able to bear the weight anymore, if the infection is just too much, or if the blood supply, which is a huge important factor in the leg healing, the vascular supply, is too poor, and there's not an option to get more blood down there to the leg, then an amputation is actually a good option. And so we don't necessarily view it as a failure. We view it as, how can we make the amputation the most functional amputation, so that the patient is back walking and dancing and doing whatever they want to do. The first thing is, what are all the things that you want to do? So there's patients that want to golf. There's patients that like to boat. There's patients that like to swim. So what are the things that make you tick? And once we find out those things, we have the patients meet with a prosthetist who goes over the goals of the new leg. And then we work very closely with the prosthetist to achieve those goals. Chronic pain is a big component in amputee's life, and phantom pain can be very debilitating and can be scary to think about. So we are focused on that here, and part of part of our team actually includes a peripheral nerve specialist who is within our department, who we talk about certain cases and patients that have pain, and are there ways to do things in the operating room during the amputation to prevent pain down the line. So that's one of the clinical focuses here that Dr. Attinger and Dr. Barber are looking at as ways to prevent pain down the line. There are certain considerations like what we call a painful neuroma. In other words, the nerve at the end of a amputation stump is inflamed. And sometimes a simple surgery by a peripheral nerve specialist can get rid of that pain. Patients here are very satisfied with their amputations, and I think part of it is, again, the long discussions before surgery, the amputation support group that we have, the patients get together and talk about different subjects, and then these are lifelong patients that we see from beginning all the way till to much later in life, and so we keep a very good eye on them, and by working with prosthetists that keep us focused on how they're doing. They're actually very fulfilled, and it's a hard thing to think about losing an extremity. But with the prosthetics that are available now, patients are extremely functional. In pants, you can't even tell when patients walk. They have a normal gait. Usually their functional outcome exceeds what they thought it was going to be before surgery. So there are many surgical techniques that we use, and that's part of plastic surgery training. And we call it a ladder, we call it a reconstructive ladder actually, where there's simple techniques on sort of the lowest level of the ladder. And those can be things like just simply re-excising or cutting out the wound itself and closing it with stitches. And that's called primary closure. And that's pretty simple to do. However, we have to make sure that that patient is going to heal and make sure that their intrinsic factors like diabetes and the other comorbidities are managed well so that they can heal with primary closure. And then as you move up the levels of the reconstructive ladder, we call it, there's local tissue flaps. In other words, if you have a defect somewhere, let's say a hole on your arm, you can actually move some of the local tissue and make a little incision along that wound and rotate tissue, your own tissue, to fill the defect. And that we call a local tissue flap. And then there's as you move up, there's muscle there's certain muscles in your body that you actually don't need to live, and those muscles we can actually use again to rotate in, to fill a hole, to provide vascularized tissue into a defect. And then the highest level is what we call microsurgery, where we take a piece of skin, usually from the thigh, and we dissect a blood vessel that's going into that skin, and we remove that from the thigh. And then the blood vessels that we've dissected, we place on the extremity or the defect on the foot, and then we rehook up the artery and the vein. So we operate underneath a microscope and use tiny sutures that are smaller than hair, and we actually hook up the arteries and the veins and allow that piece of skin to live down on the leg or wherever the defect is. So that's called microsurgery. Which is a little different than just a plain skin graft, which is another way to get wounds to heal. And a skin graft is where we take skin without the blood supply and we shave it from a part of the body and we put it down on wherever the wound is. And we want that skin graft to stick on the wound and take. And so a skin graft, we want it to basically become new skin down on where we've put it. The other factors to save a limb are really to look at the blood supply. So we work very closely with vascular surgery to make sure that there's good blood supply going down to the limb. Sometimes that patient needs a bypass. In other words, needs new blood brought down there. We work very closely with orthopedic surgery. Sometimes it's a bony problem, so that the bones have collapsed, or a Charcot problem. So our orthopedic colleagues on our team will repair the bone so that so that that's not the issue. So it's sort of it's multifactorial to save a leg. So from the blood supply to the bones, and then finally to the skin, and seeing if there's techniques that we can use to provide more skin to close the defect. What we're doing for Achilles tendon here involves the microsurgery that I spoke about. And what happens in the Achilles tendon sometimes is patients that are otherwise healthy have ruptured their Achilles tendon for whatever reason or another, and many of them have had surgery to repair the Achilles tendon. However, that surgery hasn't healed for one reason or the other. And that's very rare. Usually greater than 90% of Achilles tendon ruptures and repairs go on and do great. The very rare patients that aren't doing well sometimes have an infection in the area. So our first goal is to control the infection and get the wound as clean as possible. And then we do microsurgery, in other words, use some fascia from the thigh. And with the blood vessels, we roll up the fascia and make a new Achilles tendon, almost like a burrito or a fruit roll up, and roll it up and make a new Achilles tendon and put it down, where the old Achilles tendon used to be on the ankle, and then hook up the artery and the vein so it's vascularized. And then sometimes you also need skin as well down where if you've had an infection down on the Achilles. We're constantly looking at ways that we can use microsurgery, in other words, flaps, to heal lower extremity wounds, and we have a big focus on that here. So for the Achilles tendon, or sometimes for bony defects of the foot and ankle, are there ways that we can use free flaps, we call them, or microsurgical flaps that include bone with them? The specialties go from vascular surgery, which is very important to make sure there's blood flow, to the arms if we're operating, the legs, very important. Infectious disease, physicians who are managing issues with infection. We take cultures in the operating room anytime that we debride wounds, and those cultures are very important to guide how long antibiotics are needed, how much antibiotics, whether or not you need pills versus IV antibiotics. So infectious disease is crucial. We also work with internal medicine doctors who are helping us manage different issues with patients, their heart, their lungs, their kidneys. And then rheumatology is also a very important part of our team. Autoimmune diseases can prevent wounds from healing. And those are very important, that you have a rheumatologist that is going to supply medication that actually gets the wound to heal and not surgery. So you have to be able to choose whether or not you need surgery versus medication, because sometimes in the autoimmune population, if you do surgery, it actually makes the wound worse. We also have a hyperbaric physician, hyperbaric oxygen, which plays a role in diabetic bone infections, radiated wounds. So that's also a big component of our team. And we have podiatrists who are specially focused on diabetes as part of our team, and orthopedic surgery, who are focused again on the lower extremity or the diabetic population. And the prosthetists and podorthotists are also very important, because after we do all the surgery and we get the patient to heal, they have to have good shoes. They have to have good shoes that are going to prevent this from happening again. What we like to do is look at all the data that has been written on whatever new idea or new dressing is out there. And there's good data that honey, which is not honey from bees, it's medical grade honey that actually comes from trees, that honey can be very helpful in some wounds. So that's something that patients are surprised about. Sometimes we say, we're going to put honey on your wound. But that will actually help with what we call biofilm, which is where bacteria has set up in a chronic wound, and the bacteria are not necessarily making you sick, but they are colonized that wound to a point where it's not going to heal without getting rid of the biofilm. So if you can't do surgery on the wound, sometimes we will use things like honey. We also use maggots, which some patients are very surprised that we will mention that we're going to use maggots on their wound. However, these are medical grade, maggots that are flown here from a laboratory. And we use that to debride wounds. So maggots actually are unbelievable debriders, and we put an occlusive type dressing around a wound, and we allow the maggots to debride the wound. And usually within 2 to 3 days, the wound is clean, and that will aid it to go on to heal. Those are usually used for patients that can't have surgery. If they're too ill or frail or sick and they can't have surgery for debridement, or if it's too painful for us to debride the wound, then maggots are very helpful, and we use that in the hospital. Sometimes we do things like leech therapy, which again is another kind of interesting wound healing mechanism that we do. Sometimes if the flap or the different incisions that we've used to help a wound heal isn't getting enough blood supply, the leeches actually aid in keeping the blood thin in a certain area of the flap, and they can also help by preventing what we call venous congestion. And very rarely do we need leeches, but we do order those sometimes and use those. So the role of hyperbarics is pretty exciting, and what happens is when you go into a pressurized chamber, and these are chambers that are clear, so actually patients are inside of a little chamber, they're watching a movie, and there's a tech right next to them. The patients are dropped under pressure, so it's almost like scuba diving, and by going under pressure, because of the physical properties of gases, you can give much more oxygen to the patient. They have a series of maybe 5 or 10 what we call dives or treatments in the chamber, and then we really look at the wounds. We don't want to overuse hyperbaric in case surgery would be better. So it's an adjunct that we use. The data is very good for hyperbaric medicine on certain diabetic lower extremity wounds that have bone infection. The data is also good for head and neck, what's called necrosis of the mandible. So patients that have had radiation or for whatever reason their jawbone has an infection in it and they need to have teeth extracted and things like that, hyperbaric has been proven to be very important in the management of that. And then radiated wounds as well, as the data is pretty clear that by using hyperbaric oxygen, sometimes before surgery, we can get a patient's wound ready for a skin graft or a flap or other surgical techniques. Well, patient safety is very important to us, and we have simple things like checklists that we take very seriously, and we stand there with the entire staff in the operating room, from the nurse to the anesthesiologist to the medical student to everybody stands, and it's sort of complete silence, and you do what's called a timeout, where you check the boxes and make sure that everyone's on the same page, that we have the equipment that we need, that it's a very safe environment. And I think by following the checklists and the protocols that everybody takes very seriously, especially on our team and pretty much throughout the hospital, it's a very safe environment. Because we're a referral base for many different hospitals and clinicians around the area, because our results are good, and because we critically look at and analyze our results and publish them in terms of limb salvage rates, how functional amputations are, how fast patients are healing. So by publishing those and really critically looking at our outcomes, patients and practitioners know that that we do a good job and that patients are healing. And so because of that, we do get the most complex patients.